Second stage surgery in implantology represents an unrepeatable moment for soft tissue management, which makes it possible to obtain a good aesthetical result. In this case, a big difference in level is evident on the vertical plane between the edentulous axis, where implants have been positioned, and the gingival margin of the remaining teeth. It is therefore important in this second stage surgery to compensate the different levels in such a way that both the implants and the natural teeth are on the same level. Firstly, it is absolutely necessary to avoid releasing incisions. Clinical crown lengthening must be carried out on the natural teeth, whilst on the implants a coronally positioned flap must be performed in order to obtain a gingival margin with a homogeneous height. From an aesthetical point of view, the important thing is not so much having a gingival margin, which is perfectly on the same level. However, it is important to avoid steps and abrupt differences of level on the mucogingival line. This is the reason why vertical releasing incisions are avoided. An incision is made at the centre of the crest so as to divide the mucous fibre in two equal parts at the level of the implants, and at the level of the natural elements an incision is made in the sulcus, redesigning the papillae, decidedly more apical than the natural ones. Therefore, a full thickness flap is raised at the level of the implants, and in the same way, the same type of flap is raised on the natural teeth to expose the bone ridge. The flap must amply exceed the mucogingival line, and, at the end of the operation, must be positioned apically at the level of the natural teeth, but coronally at the level of the healing pillars on the implants. This is because the healing process in osseous resective surgery, with apical positioning around the teeth, will lead to a maturation of tissue which will migrate in a coronal direction, whilst the healing process at the level of the implants will lead to the inevitable contraction of the matured tissue. So on one side, at the level of the natural teeth, the tissue will grow, even though we don't know by precisely how much. In fact, in literature there isn't certain data concerning this, but certainly the tissue will grow around the teeth. On the contrary, around the implants the gingiva will recede and the gingival margin will become decidedly more apical. It will be necessary to wait 6 months before the healing process and the maturation of the tissue gives a gingival margin that is more or less at the same level. Clinical crown lengthening is carried out on the natural teeth. First, using hand chisels, an ostectomy is carried out, and scalloping at the vestibular level. At the lingual level, the removal of supporting bone. The roots are planed to increase the interproximal spaces and carry out the clinical crown lengthening. The healing pillars will be positioned above the implants, and at this point the bone margin is still high at the level of the teeth, but the difference, thanks to this surgery, has been decidedly reduced. At this point the bone level is also compensated through the correct position of the flap by means of apically stabilizing sliding periosteum anchor sutures at the level of the teeth. The flap is positioned apically. The opposite occurs at the level of the implants where, with coronally sliding flap sutures, it will be positioned coronally. Penetrating apically at the alveolar mucus level, the periosteum is anchored, exiting in the dead space, re-entering the papilla a few millimetres more apically with respect to the necks of the newly designed papillae, passing lingually, catching the lingual flap, and then returning vestibularly after having engaged the lingual flap with a horizontal mattress suture. Returning vestibularly to make a knot. The periosteal anchorage, which was carried out initially at the vestibular level, with this closure, will give the flap apical stabilization with respect to the bone ridge. There will be healing at the level of the bone margin, second intention healing, with coronal migration, which can't be exactly quantified but will certainly occur. At the level of the implants, the opposite occurs. The simple interrupted sutures can be seen which will take the margin coronally. So the gingival margin will be positioned around the implants, decidedly more coronal with respect to the gingival margin at the level of the natural teeth. As it is already possible to see, the difference in level between the gingival margin at the level of the implants and the level of the natural teeth is in favour of the implants. This is expressly sought during the healing process. The tissue will recede apically at the level of the implants, whereas it will grow coronally at the level of the natural teeth. The suture is completed to obtain good adaptation of the gingival margin around the implants for coronal positioning of the flap. Once the suture is finished, it is advisable to position a surgical dressing over the wound on the natural teeth for protection, because the flap has been positioned apically to the bone ridge, whilst at the level of the implants there aren't any particular problems. The completed suture can be seen. Using a probe, it is possible to see the two different levels of the gingival margin, positioned coronally to the implants and apically to the natural teeth. There are certainly about 4 mm difference. The initial situation, where there is a big difference in level between the implants and the natural teeth, can be compared with the prosthesis, which thanks to this surgery is more or less at the same level as the natural teeth.